So thank you very much. It's very nice to be in Bucharest again. I would like to thank Mrs. Kachulan for having me here. I would like to express my gratitude and my pride to be part of OMTRO program, and to my friend Andrei Georgiou. So I know that was a bit difficult to translate the title of my presentation, but I hope that the presentation will pay back. So you don't see them, but I see them. I have some very nice colleagues here supporting me around. So it makes me even happier to be here with you. Actually, Romania is like my second home. So I will not take more time. So, as this gentleman says, common sense is not a gift, but it's a punishment, because you have to deal with everyone who doesn't have it. It's something that we see, unfortunately, more and more the last time. Let's do some prehistoric talking. So in the beginning, our physiotherapy knowledge was based on basic anatomy, and it was basic knowledge on treating patient after observing and responding and seeing how the patients respond to treatment. It was more or less empirically. So many concepts were developed based on basic sciences, observation and clinical experience, and each concept developed its own techniques and explanations about the mechanisms and the techniques that work. So the evolution of science brought some needs that experience is not enough anymore. We need more and more science because it's involved, and evidence-based practice emerged the last years. So we have an increased demand of this evidence. And what is more important is that we need new explanation models. There is a pendulum in our profession and in science too, because in the beginning we were bone crackers, bone setters, we were moving joints, and we were dealing with some soft tissue. After a while we had some disc, vertebral alignment experts, some of them still exist. There was a trend of transverse abdominists, trainers and protocols. Then there was another, we moved to the other edge of the pendulum, that manual therapy sucks, does not work. Palpation sucks, we don't need palpation. We don't need hands-on techniques. We don't need some skills. We don't have to touch a lot of patients, but to talk more to the patients. So this brought up the need for common sense and evidence. So we had a revolution of scientific evolution, which has increased. The demands for answers that are valid, have strong evidence support and clinical use. What are we all looking as physiotherapists? We're looking to have explanations for the mechanisms of pain. We need to have validity and very strong scientific explanations for the diagnostic tests and the mechanism of techniques that we use in our treatment. Well, is that wishful thinking or is it a reality? Unfortunately, it's not possible to have evidence-based answers for all the questions that are raised, because we have methodological limitations and ethical limitations. And also, moreover, we have complexity of symptoms and differential diagnostics, which makes things even difficult to put in a certain framework all the time. And we are all familiar with the pyramid of evidence and the systematic reviews, for example, the meta-analysis that are in the top of the pyramid of evidence. But if you see how we start in our training as physiotherapists, and maybe in many other professions, on the top, which is a PhD, for example, we use the common sense sometimes less and less. So what is evidence-based practice? It's about explanation and take-home messages, and I will give you some explanation, some examples about that. So let's see some articles. There was a recent publication that says that cupping for patients with chronic pain, it's a systematic review and meta-analysis, which is top of the top quality. But it says finally that it's cupping for patients with chronic back pain is with no use. So what is the take-home message of a paper like this? Where we can use this knowledge and this evidence that comes from that? That if somebody thinks that he will use cupping for chronic pain patients, it's not going to be an evidence-based approach, but more or less it's like an alternative and not valid approach. But on the other hand, if we know about what is a chronic pain patient, did somebody that knows what is the chronic pain patient thought for 1 minute that cupping would help him? I think not. So let's move on. So there was another paper that says that, for example, the effect of two manipulative therapy techniques and their outcome in patients with sacroiliac joint syndrome. So that was a single-blind randomized clinical study back in 2012 that was carried on in Shiraz University of Medical Science in Iran. And the paper included 20 female patients, and the inclusion criteria were female patients who had an acute unilateral or bilateral SIJ syndrome, so sacroiliac joint syndrome, during the past 6 weeks. Good. So the conclusion was that both treatment techniques, so sacroiliac manipulation or lumbar manipulation, significantly improve pain and function disability in patients diagnosed with sacroiliac joint syndrome. And one other conclusion was that neither sacroiliac manipulation nor lumbar manipulation found to be more effective. So sacroiliac manipulation versus lumbar spine manipulations. Therefore, manual therapy spinal thrust manipulation may be considered as an effective treatment option for patients with SIJ syndrome. So I'm a manual therapist, I would be very happy normally about that. But there is a problem. Let's consider some things. The study was conducted in Shiraz University in Iran in the year 2012. Only women were included. So let's think about the cultural and religious characteristic of the country in this time, cloth-wise. So it is more likely that the women that were examined used to have the clothes on. It's a high possibility. And the other problem is that there are no techniques that are targeting only the sacroiliac joint that don't affect the lumbar spine and vice versa. So you can manipulate or think that you manipulate the sacroiliac joint and you actually manipulate the lumbar spine, or you can think that you manipulate the lumbar spine and you also affect the sacroiliac joint. So what is the validity of a paper like that? And then there's another paper that says effect of spinal manipulative and mobilization therapies in young adults with mild to moderate chronic low back pain. This is an randomized clinical trial. So the participants were patients with chronic low back pain, being between 18 and 45 years old, reporting low back pain constantly or most of the days for the last 6 months. And the inclusion criteria were participants that had at least 3 or 4 clinical characteristics that have been associated with positive response to spinal manipulation. So symptoms less than 16 days, no symptoms distal to the knee, no fear avoidance behavior, at least one hypomobile vertebral segment, at least one hip with internal range of motion greater than 35 degrees. And you can see here the 3 criteria they had in the paper. So if you see what they did as a treatment, was the participant was placed in a position similar to that, so side lying with facing the therapist. The painful side was facing upward, and the lumbar spine was positioned in full flexion until they felt the spinous process of the affected lumbar vertebra begin to move. I'm not going to talk about the validity of palpation and all these things. We step away from that. But what happened was that the clinician applied a rapid thrust by pressing the shoulder and the pelvis on the other side, resulting in a rotational force on the hypomobile segment. At least this is what they thought it is. And if a cavitation, so the crack was hurt, the treatment was considered complete. So the conclusions they made is that spinal manipulation and mobilization were no more effective than a well-chosen placebo in reducing pain and disability in patients with chronic low back pain. And these manipulative therapy techniques do not appear to be effective for chronic low back pain, at least among relatively young individuals with mild to moderate back pain. Okay. Let's think about it. First of all, in the inclusion criteria, they had no patients with symptoms of articular dysfunction like a closing mechanism, like we say compression mechanism, like a mechanically induced pain. So why preposition? And then the other question is, why would you preposition a patient in a flexed position? Why don't you choose a preposition in extension that can better lock the lumbar spine and converge the applied forces more likely to the desired segment? If the therapist applies the thrust in flexed position simultaneously at the shoulder and in the pelvis, so giving a big lever, it is possible. Is it possible to converge the applied forces to the targeted segment if you are in flexed position? It's not likely. So if you do it in extension prepositioning, this can be achieved better. So it looks like the cavitation is more difficult to produce because the position of the joints is not at the end range when you preposition in flexion. So what is the clinical use and what is the take-home message from a paper if we choose the wrong kind of patients? If we choose chronic pain patients versus mechanical induced pain patients. If we choose patients with symptoms that are not eligible for manipulation. If we apply techniques that are not the best chosen for that. And if we apply a questionable technique like a manipulation and flexion in a questionable way, the so-called $1 million maneuver by pressing one shoulder and the other part of the pelvis. So there is another paper in recent 3 years ago, spinal manipulation for chronic low back pain. Is it cracked up to be? So what is the take-home message? So why on earth a physiotherapist who knows what chronic pain is would choose manipulation to treat chronic pain patient? There's no point. That's the main idea. There is no point to treat a chronic problem with a manipulation that is not designed to treat chronic pain patients. Here's another very good paper from a very well-known and well-appreciated colleague, Mr. McCarthy, and they compare targeted thrust manipulation with general thrust manipulations in patients with low back pain. So, as the title of the paper says, a general approach is as effective as a specific approach. There is not more reduction in self-reported pain disability when using a targeting to a symptomatic level than using a general thrust technique. And there is no mention which exact technique was used. The manipulation was performed by an osteopath with 13 years of experience, and the inclusion criteria were people with low back pain between 20 and 60 years old, with pain for at least 3 weeks, and a Roland Morris disability questionnaire score of 4. So this is a very good paper, but what would be the take-home message? The result of a general manipulation versus a targeted manipulation is the same. But why do we instruct our students to learn, and why teach our students to learn targeted techniques? Because one of the most usual mistakes or one of the usual side effects we see with patients is that if you are increasing if you deliver a non-targeted manipulation, the most likely is to increase pain. So maybe you don't create problems to your patient like codequine or something like that with a lot of incidents. But what you do is that the beginners, instead of doing manipulation with a fast, with high velocity, they change the velocity and they put a lot of force. So if you have a patient having a manipulation, a general manipulation from a beginner, it's more likely that the beginner will put a lot of force instead of high velocity, and this will create more pain. And this is why we should choose to teach targeted manipulation. Not because it's a different in the result of pain, but it is safer and it's easier from a beginner to learn how to preposition, how to evaluate, how to examine, and how to deliver the technique. So that was a very interesting paper. It's back in 2011. It's about the effectiveness of manual therapy in supraspinatus tendinopathy. So the objective was that it was a randomized controlled study to assess the efficacy of manual therapy, keep it in mind, manual therapy, in the treatment of patients with symptomatic supraspinatus tendinopathy, and they had 3 groups. One was a supervised exercise program group. The second group was a supervised exercise program combined with joint and soft tissue mobilization. And the third group was a home-based rehabilitation problem. So the conclusion they did is that supervised exercise, supervised and manual therapy, and home-based exercise are all effective and promising methods in the rehabilitation of the patients with subacromial impingement syndrome. The addition of an initial manual therapy may improve the results of the rehabilitation with exercise. So me as a manual therapist I should be very proud of this, but things are not like that. So let's take a deeper view. Say 77 patients between 33 and 55 years with partial supraspinatus tear and or subacromial impingement syndrome diagnosis were included in this study. The inclusion criteria for the study was the presence of subacromial impingement syndrome stage 1, rotator cuff tear, diagnosed by clinical examination and magnetic resonance imaging, so MRI. So take a look at the manual therapy treatment. They did deep friction massage of the supraspinatus muscle, radial nerve stretching, that's what they said, scapular mobilization, glenohumeral joint mobilization, proprioceptive neuromuscular facilitation techniques. The patients in all 3 groups had range of motion, stretching and strengthening exercise for the rhomboid, levator scapula, serratus anterior, and rotator cuff muscles. The funny thing is that none of the manual therapy techniques and exercises are included in the evidence-based protocols for manual therapy, for tendinopathy, excuse me. So you have a big difference, and you have tissues from patient to patient that are very different. You can also see here from a paper from a German physiotherapist who did a kind of research with MRI. You see the finger of the palpating finger of the physiotherapist, how far it is from the facet joint. You can see it here, the finger of the physiotherapist, and the facet joint here and here as well. So what can you say? Can we generalize? We are in a dilemma. Some people, manual therapy is effective. Some say manual therapy is not effective. Some people say palpation is reliable, or some say it's not reliable. Of course we do need palpation skills, because we treat patients like that too. We treat patients like that too. And unfortunately, we treat patients like that too. So if you don't palpate, if you don't know how to touch the patient, how you will feel and how you will deliver the treatment in an appropriate way. So let's conclude our presentation for today with some take-home messages. Do we need evidence? Of course we do, and we need it badly. Do we have evidence for everything we do? Unfortunately, no. We wish we had. The structural model of explanation is insufficient. We need a new paradigm or model approach to explain how our techniques work. We can't treat everything just by consulting or talking. There are no black or white approaches. Very often we have to use our hands and be careful how to explain the mechanisms. Above all, we need to use common sense when we read the literature in order to see the validity of the information. I would like to thank you with your attention, and just keep that in mind. Common sense, unfortunately, is like deodorant. The people who need it most, they never use it. Thank you very much for having me here.